Dr. Kennedy was called away, but Leah and Jim are still here, so I'm going to get a couple of the mics up here for everybody. And then I just ask if you have any questions, just stick your hand up here, and I'm going to come over with this mic and try to get everybody so we can hear everything. So thanks for your patience.
Hi, thanks for a great presentation. 2 questions from the last talk on organizational planning, structure and process. On your slide, what is a regional care team? You listed a couple different positions that you'd never discussed. You have engagement specialists, peer mentors. I know what they are, but you also had a transition care coordinator. You only list the healthcare coordinator and the clinic coordinator. So the structure question is, are these actual positions, or are these tasks that the clinic coordinator is assuming but broken out into different tasks? Or are these actually really different people? And if so, how in the world do you afford them all when you're servicing a high-risk population? And the process question is, since they're regional and continuity was the original model value that Dr. Kennedy discussed, how do you pull all these people together to discuss the case where and when to create a culture of continuity, because it appeared massively complex and fragmented?
Yeah, so the couple questions that you had. So in this box is really talking about potential services and roles at the clinic that person goes to. Not every clinic has all these roles, but when we're working with our providers, these are the roles that some clinics actually do have. So we don't necessarily have these. The roles that we do have are within the circle. The community outreach workers, so this we have in one of our regions, our coastal region. We're working on how do we do that in the metro area. It's kind of also a prioritized strategy or component coming from both the state and federal level of how do we utilize traditional health workers, community health workers. And so this we don't have on every team, but the rest we do have on every team. Within you asked also how do we what's the continuity of care?
Well, there were those check marks on the box where it says engagement specialist, peer mentor, transitions care, but on the last slide of your workflow, you didn't discuss any of those.
Yeah, so this group is what services or roles are potentially within the community clinics or primary care clinics or specialty clinics. So those aren't actually on our teams, but we want to see them as part of the team to say who is the best person to serve. If the clinic is already engaged with that member and has that member really well wrapped, there's no need for us to get involved if we don't want to kind of step on toes or do that. So yeah. And then your other question around the continuity and where we kind of discuss cases or how do we best partner. We have, so our health resilience specialist role, which isn't necessarily called out here. I sort of called it the behavioral health care coordinator community-based. So those staff members are actually embedded within primary care clinics, and they see themselves as part of the clinic's care team, and they often discuss cases with that care team. But then they also come back to CareOregon and have a regional care team here and sit with the other members of that team. We're all actually up on the 9th floor here. And we've grouped our care coordinators physically together so that they're all kind of sitting in the same area. And every week, depending on the team, every week has a team meeting and a kind of case consultation or ICT that they can utilize to discuss the members that they are working with and potentially even sharing some of the interventions for one member, let's say.
And I would just add, while it's not listed here, there is a clinical pharmacist assigned to each of the, well, it's support for not only the clinics, but internally in the regional care teams, there's a pharmacist assigned to each regional care team. So as the provider and the regional care teams prioritize a patient one way or another, we can get a pharmacist help if we need it.
I feel like I should do karaoke with this mic, but I won't. I truly appreciate the work that you do. I see a lot of CareOregon patients in the field as a nurse practitioner. and they're very, very appreciative of what you do. Probably 1 in 15 clients, I make an urgent care referral, but there's no feedback loop, as I never hear and lose sleep or worry about the clients that I've made the urgent care referrals to.
And when you say urgent care, you mean a care coordination referral to our teams, or? Yeah, so we are working on what is the best way to notify the referent. How do we either include the referent in that person's care if they're already included, and really making sure that the people who are involved with that person, including what might be their family or significant other, it's sort of dependent on what the member wants as well, but really trying to incorporate whoever is already working with that member into that care planning process, and to make sure that you are aware, we got your referral, here's the next step of what we plan to do with that referral. Here's the care coordinator that's going to be assigned, here's their contact information, and really working to make sure that when we do receive that referral and assign a care coordinator, that we are closing that loop and making sure that if you're still engaged with that member, that you're engaged in the care coordination as well.
No, I feel like as a nurse practitioner, the electronic medical record, it's like a freaking albatross around my neck. It doesn't seem to incorporate focusing on patient empowerment, on affirmations, on what the client does well. It just wants us to ask 500 questions and do 50 tasks. And I wish that the EMR could be more facilitative.
Yeah. Agreed.
Good feedback.
Oh, I was curious about the way you have a layer of assessment and care planning prior to any patient contact, and potentially without access to the EMR, maybe just to like claims data. And I'm wondering, have you been finding that pretty relevant down the line when somebody does make, like, has that been, how true has that been to what you eventually determine to be a patient's needs or what they want to work on?
Yeah, so on the proactive case finding side, our triage coordinators do sort of an initial assessment without the member or even really provider information. It's sort of just based off of the information that we have. And then once we actually assign a care coordinator, that's when they're outreaching to providers. They're looking in the clinic's EMRs. We have access to some of the EMR systems. We're calling the member to kind of ask those questions around how do they view their own health care, what are their care coordination needs. Did I answer your question?
No, my question is, have you looked at, my question was really, have you thought about or compared the initial needs assessment
With ongoing?
Yeah, with what presents later, and which perhaps in retrospect were the driving needs?
Yeah, some of our care coordinators might be able to answer that, but when we were building the assessment, we were really trying to figure out, okay, if we're looking at these questions, how do we best kind of identify an issue based on the way somebody answers a question, and then based on that, what's maybe a universal intervention that makes sense with that issue. But I think what our care coordinators find is that while some of that is pretty simplified, they actually go in and manually add to that care plan. They manually adjust all of those issues and interventions kind of themselves. And Jennifer might be able to speak to that more. She's one of our care coordinators.
Yeah, just to add on to that, yeah, the assessments that are initially generated either in the proactive or when we just get a call from a member or a provider with an initial question, that's where we start, but it's really intended as a evolving kind of living document. It's not intended as a prescriptive, we will only do this and nothing more. And so data is certainly one of the places and one of the resources we have to help identify some of those patterns, but every case that's open in care coordination has some element of direct contact either with the member or the care team that's working with them. So it's really evolving, and those care plans we build with the intent of being able to share with members and ask, is this reflective of what you feel works for you or not, and adjust based on that feedback. So
perhaps it's just not relevant.
Well, if I could add, I'm on the steering committee for this work, and watching everybody work super hard on this, there's a lot to do here. And I think the key is, now that the populations have been labeled, that the information and IT structure has been built out a bit, that the flows are coming between internal and external asks to focus on somebody, it's back to what I was describing earlier, is getting this repetitive patterns of care and talking with people like you about how it went and how do we improve. And every provider's in a slightly different place of need and what works for them. And so it's finding that win together that we can repeat. And so it's a bit of a one step leads to the next step. And so your questions are excellent, but it's a question of how do we get you with a few patients to connect to the right person to explore what worked and what didn't work. And that's the key right now. And then we can build the capacity.
And as far as the assessment and care planning, like the way we have it now, this is brand new for us and brand new for all of our care coordinators. And so we implemented this in April. It obviously took a couple months for our staff to even get used to the system and documenting that way. And so I think like just now we're assessing, do the assessments make sense for the work that you're doing? We're going to be integrating the behavioral health benefit in January, and we probably need to redo that assessment to incorporate behavioral health questions. There's a big push on the pediatric population, and our questions, are they more related to adults? Probably. Do they really assess the care coordination needs of a child? Probably not. And it's really getting feedback from our staff around, does this workflow even make sense? Is it actually a barrier to your work? Where would you guys suggest that we sort of edit and pivot around how we utilize the care plan? And that's sort of, we're just kind of beginning that phase. Yeah. Yeah.
So I was just going to add on a little bit to your answer, but maybe you feel like it's been answered well enough. This really does seem like a work in progress.
Very much so, yeah.
This is for pharmacy, for deprescribing. How would you suggest when clients are not compliant with their medication because of side effects and or hoarding, how would you suggest to write this to the primary care provider?
How to communicate that with the
Yes.
primary care provider? In a trauma-informed way? Or just like in a CYA
cool
way? Okay, in a cool way. In a cool way. To sound smart? Okay. Well, in one class that I had, we were told to say, patient is creative at getting their needs met. Which means that they might be hoarding medications, or they might be triangulating or manipulating, but really we see these things as adaptive behaviors, adaptive to trauma. So it serves a function. So if you don't want to be alienating, you could say creative in getting their needs met, or you could say patient is complex. As far as non-compliant, I had a caregiver who chose their own warfarin doses for their mom, who was 80. And I wrote, caregiver chooses warfarin doses. And I have spoken to them about, I've provided education and I've provided recommendations, and caregiver still chooses their own warfarin doses. And I put that in every note. So, yes.
And I would just add to her comment, I just had a discussion literally last week with a provider who is a provider at Central City Concern with patients with also behavioral health challenges. And he said he made it a routine question with every visit when he was working on refills, as I'm working with you to get you more medication, how much of this do you have at home? And not in a grading or a negative sort of way, but exploring what their situation was, and then working with how they were answering that question, kind of exploring more.
I was just going to respond to that. I met with Kara Tannenbaum, who's the director of the Canadian Deprescribing Network. She was in town 2 weeks ago, and we asked her just that question. Interestingly enough, many of us in Portland said, do you teach the doctors how to do motivational interviewing? And she kind of rolled her eyes and said, I know how important that is to all of you down here, but she said, we are working with over 5,000 doctors now throughout all the provinces. I mean, because it's national health care, they get away with that. It's a wonderful model. And she said, we found that when we had the patients request a change of drug, or the pharmacist would send a recommendation, in major categories was between 20 to 27% change. When the pharmacist sent materials that they've worked on, and they're working on them now drug by drug, from deprescribing.org, specifying, the pharmacist would send to the family doctor data from a publication saying, this is evidence-based material showing how this could improve. With a publication, they tripled the rate of the doctor making the change. She said, do I believe that that information actually is important to the decision process? She said, personally, no. I wish they would just use motivational interviewing. Will the doctor participate without structured data? No, because from their culture, doctors are evidence-based, and they're using evidence-based materials to give the drug. So she said, we find that our doctors, unfortunately, need evidence-based guidelines to do the motivational interviewing, or they won't participate. So they're now creating apps with data, so the doctors can go, the pharmacists can direct them to that app and say, here's the data backing up my recommendation. And they're getting much better response.
Great, thank you.
That kind of speaks back to your structure.
Yeah.
Have a structure.
Other questions?
Sorry, I'm a lot of questions. I apologize. Jim, question for you. You had a slide about affirmations and life gaps and goals, and you mentioned a couple of tools when you were on that slide. A lot of these concepts and content are things that I think a lot of us are using, but maybe not, perhaps not in a, I know I'm not using it in a very structured way. And if there are any sort of assessment tools that you think better encapsulate that. I mean, sometimes I've looked at social work tools for these reasons, but I'm wondering if you have thoughts on that.
So we don't have in our kit immediate tools to address what we're all observing as a need. And so I think sometimes that's the verse power and change, is to say this isn't a really important space, just like the comment about the EMR is not really structured for this, to figure out how we now support this type of activity in the correct way. And so I know Paul and others have been helping to figure out ways beyond the MEDS chart of creating these conversations in a good way that get a little bit more structured to Leah's experience, in a way that where relationships kind of have to be careful because you don't want to get too structured with relationships. So it's kind of a delicate space to work on, but I think it's an excellent area for all of us to think about. I've seen tools in other places, not for this purpose, that could probably work pretty good if we adapted them, and that's really the next place to go. Yeah. So if you spot stuff, or you even have an idea that you just need somebody to help you turn it into something, Paul's your man to kind of throw an idea at him and see if it sticks.
Yeah, we like to try stuff out. Do a lot of experimenting in pharmacy. Any other questions that are burning through the room here, folks? How about we give it up for all of our presenters today?